and to discuss the last few abstracts. Thank you.
Thank you so much. Yes, I have the pleasure of talking about lidERA and the advent of adjuvant SERDs. I have no significant COI. So let's start by talking about the history of targeting the estrogen receptor in hormone receptor positive disease. And you see a timeline here. The red drugs, of course, are those that are directly targeting the estrogen receptor or estrogen levels. And the pink are those that I'm going to call resistance targeting mechanisms that add to endocrine therapy. And what you can see is, aromatase inhibitors, tamoxifen, fulvestrant, then a gap with a number of resistance targeting drugs, and then recently the advent of these really terrific oral SERDs and also one PROTAC. This is all in the metastatic setting. Now, the early breast cancer non-metastatic setting is a shorter story, right? We have tamoxifen, AIs, OFS. We had the addition of abemaciclib and ribociclib as, again, resistance targeting drugs to add to endocrine therapy, but really not much in the last 20 years related to estrogen receptor targeting until now. And that's where giredestrant comes in. And just to highlight again, these are the first positive data for an oral SERD in the adjuvant setting. So I'm going to frame this in a series of questions. We'll start with the obvious one. How will lidERA change practice? So you see the design on the top. Again, it's a one-to-one randomization to giredestrant versus standard of care endocrine therapy monotherapy, tamoxifen, or an AI-based treatment in just over 4,000 patients. I'd like to point out a couple of elements that I think are worth noting. The first is stage 1 was allowed in this trial. That's a little unusual in this setting. They had to be high risk, but they were allowed. Number 2, in the premenopausal setting, it was giredestrant plus OFS. Again, standard of care, as typical, was AI plus OFS. Tamoxifen did not require OFS. The third is prior endocrine therapy was allowed, including CDK4/6 inhibition, but only for 12 weeks, and once patients entered the trial, CDK4/6 inhibitors were no longer allowed. So these are the participant characteristics that Dr. Bardia just went over. A couple of things I'd like to, again, note. First, about 40% are premenopausal, so it's a reasonable proportion. The second is, while stage 1 is allowed, it was a minority. Most patients were anatomic stage 2 or 3, and most were node positive, including a substantial proportion with N2, N3 disease. Not surprisingly, given that risk profile, most patients had received prior chemotherapy. And then finally, there is a risk score that was used in this trial that I'm going to talk about in a second, but just note that the majority of patients fell into the high clinical risk category. So I'm highlighting this a little bit because I think it's important. It is one of the stratification factors, along with region, prior chemotherapy, and menopausal status. So patients had to be medium or high risk according to this score. All node-negative patients that came into the trial fit in the medium risk category, and they had to have some high-risk biologic elements, as you see here. N1 disease could be either in the medium or high risk, depending on whether those other features were low or high risk. And so in high risk, you have N1 with high risk features and anything that was T4, N2, or N3. And note that about 70% of the patients in the trial fell into this high risk category. So these are the primary data. The IDFS met its pre-specified statistical threshold for positivity with event-driven difference, which you can see quite easily here in a stratified hazard ratio of 0.7. So meaning reducing the risk of recurrence or death compared to standard of care endocrine therapy by 30%, and very similar hazard ratios in secondary endpoints I show here. For example, the distant relapse-free interval of hazard ratio of 0.69. These are early days, so this is only 32 months for it to reach the event number that triggered this analysis and the positive findings. It's also true that the distant relapse-free interval, again, 0.69, is trending in the right direction towards that particular endpoint, but the numbers are still fairly small in terms of events. Looking at the subset of the Kaplan-Meier that you can see that highlights the numbers a little bit, you can see a couple of things that are quite reassuring, not only the statistical significance, but also that these are quite stable. The curves started separating fairly early and are continuing to separate, although I'll caution you that there are fewer than 700 patients contributing data at the 3-year time point. But here we are. We have an absolute difference of 2.8% at just under 3 years, with similar directionality for all the clinically important endpoints, for example, a 2.1% absolute difference in distant relapse-free survival. I'd also note that the medium risk group, again, the hazard ratio, the point estimate is very similar, 0.74, but the 95% confidence intervals are very, very wide, reflecting a low event rate. Giredestrant was quite tolerable. There were a few more dose interruptions, as shown here, but there really weren't more discontinuations. And interestingly, the number of discontinuations from musculoskeletal symptoms were actually lower than with standard of care endocrine therapy. Now, there's a class issue of the bradycardia side effect. It ended up being a pretty minor issue with only 10% and largely grade 1, meaning either no or minimal symptoms. And I think that's reflected in the tornado plot on the bottom, where you can see really not much of a signal of tolerability issues in any of the domains. So let me put lidERA in context of other advances that we've had in the adjuvant setting for hormone receptor positive breast cancer. And you can see it on the top. And then going down, you have an ATAC AI over tamoxifen, and then a series of the Monarch E time points establishing abemaciclib in the adjuvant setting, and the same for NATALEE, establishing ribociclib in the adjuvant setting at different time points. So I've just put boxes around the 2 to 3 year time point for reporting for each of these trials. And what you can see is both for in the lidERA, the ATAC, Monarchy, and NATALEE, they all look pretty much the same in terms of a 2 to 3% absolute benefit and a hazard ratio living somewhere between 0.7 and 0.8. And you can also see that all of the others grew after that. So what we're seeing are similar differences, both proportional and absolute, as other adjuvant trials measured at the same time frame. And this includes a similar high-risk population as Monarch E and most of NATALEE. So to answer question number 1, the absolute benefit is small, but I believe it's likely to grow with additional follow-up, and it supports giredestrant for the high-risk group, particularly if you're giving endocrine monotherapy. The other is that although the trial population was broad and included stage 1 through 3, that medium risk group that included all of the node negatives has very few events and needs more follow-up. And crucially, CDK4/6 inhibition was not addressed in this trial. So question 2, do ESR1 mutations play a role in driving lidERA results? So we all know that ESR1 mutations drive oral SERD monotherapy benefit in the metastatic setting. We also know that ESR1 mutations are acquired. They're virtually never seen in untreated tumors. You see about 5% have mutation acquisition at the completion of adjuvant therapy, and you get up to somewhere nearing 50% after later line endocrine therapy for metastases. And in the metastatic setting, oral SERDs outperform standard endocrine therapy only in the ESR1 mutant population. You see here Acelera, which is standard of care, versus giredestrant to illustrate that. And you can see the Kaplan-Meier curves are clearly only separating in the ESR1 mutant cohort. There are similar findings with other oral SERDs, elacestrant and imlunestrant, in the metastatic setting. We don't have the data for lidERA, but given the untreated nature of the population, it's likely to be virtually all ESR1 wild type. So why did giredestrant work so much better than standard endocrine therapy and so early? I think we have a couple of hints that come not just from the efficacy of a really good drug, but also the control arm and what it's being compared to. So first, most oral SERDs in the metastatic trials have been compared to intramuscular SERD fulvestrant. I'm illustrating that here with a number of the trials across different oral SERDs, noting that the control arm is either largely or entirely made up of patients receiving fulvestrant, high proportion of ESR1 mutations, and you can see the ITT hazard ratio is in black, and then the cohort within that, the subset of ESR1 mutation carriers, is in orange, and you can see that that's really driving the findings in these trials. So what you can say is that single-agent oral SERD is better than intramuscular SERD in those with acquired resistance through ESR1 mutations. Oral SERD is similar to intramuscular SERD in wild-type ESR1. It's also true that some studies, evERA and EMBER-3 particularly, suggest that adding resistance-targeting drugs to the oral SERD may overcome this restriction to ESR1 mutant tumors. That's something that needs to be addressed further. So now let's talk some more about the control arm nature. So fulvestrant monotherapy is probably better than AI and tamoxifen. So what you see here is some first-line monotherapy trials of fulvestrant given at 500 milligrams, the standard dose, where it outperforms anastrozole. And you can see these were first-line populations of either largely or entirely endocrine-naive patients with a hazard ratio for time to progression, or PFS, clearly favoring fulvestrant. On the bottom, you see a monotherapy trial of half-dose fulvestrant, where it is basically equivalent to tamoxifen in an, again, generally untreated population. So we can certainly say that in modern times, the lidERA control endocrine therapy would not be modern therapy in the current era. When they looked this exploratory analysis of the control arm and the nature of the drugs given, they actually saw some support of this statement that the control arm contribution to the findings. There was only 16% of the patients who received tamoxifen, but you can see that there is a hint, again, this is an exploratory analysis, that the nature of the control arm matters for the giredestrant outperforming the drug, with tamoxifen clearly being much more inferior. It's also true that 80% of the patients in this trial were node positive, and more than 30% had N2 or N3 disease. None received CDK4/6 inhibition. So to answer the question of do ESR1 mutations play a role, it's very unlikely that ESR1 mutations will be relevant, so no role for ctDNA testing. It is more likely that giredestrant is simply a better endocrine therapy than AIs and tamoxifen. And then finally, assuming adjuvant giredestrant gets FDA approval, what are the other implications? So turning our attention again to the CDK4/6 inhibitor question, mature 5 to 7 year data with adjuvant ribociclib and abemaciclib show a 4.5 to 6.5 absolute IDFS benefit. Combination data for giredestrant with either drug is not at this time available. So I would argue that for patients not receiving a CDK4/6 inhibitor for whatever reason, giredestrant will be the favored endocrine therapy. For patients in whom CDK4/6 inhibitor would be appropriate, I believe an AI plus CDK4/6 inhibition for the initial 2 years, as you do now, would be preferred, and then perhaps consider a switch to giredestrant. I say that with some trepidation because that's not actually how the trial was designed, but these are practical considerations. And then finally, efficacy is better, toxicity is no worse, but cost is an issue. I show you here the wholesale acquisition cost per month for the oral SERDs that are available for the metastatic setting on the top, more than $20,000 per month, with all the other drugs being less than $1,000 per month. And so we should all acknowledge that there is a large potential impact on the national healthcare systems if giredestrant is priced similar to oral SERDs that are given in the metastatic setting. Now, there are other trials coming. So you see lidERA is here in the second line, Cambria-2, EMBER-3, EMBER-4, Elegant, Cambria-1, and Treat ctDNA, some of which are first adjuvant therapy, as lidERA was, so right out of the gate. Others awaited at least 2 years of adjuvant endocrine therapy before randomization. So there will be more coming in this space. So to summarize, this is the first improvement in adjuvant endocrine therapy in 20 years. It was a 30% proportional improvement in IDFS and other endpoints. The absolute IDFS difference is less than 3%, but it's likely to grow. Combination data with CDK4/6 inhibition are not yet available, and because of that, given the benefit in high-risk patients that are the ones that clearly are benefiting here, I would continue AI plus CDK4/6 inhibition in the initial 2 to 3 years. And we need to determine quickly if giredestrant benefit is additive to CDK4/6 inhibitor benefit. I also think that we have a real need in this setting in particular, and if anybody knows me, you know this is an argument I make all the time, but I'm going to make it even more strongly right here, that we desperately need predictive biomarkers to tailor therapy beyond the estrogen receptor, because lidERA has very broad clinical implications. So we will need both biomarkers and models to guide decision making. Thank you. I have great appreciation for the lidERA. Thank you. The lidERA team was super helpful in helping